So thank you everybody for being here again. Today we are happy to have Dr. Alice Hoyt and Joan Edelstein to talk to us about how to use policies to advocate for students' health. And here are the bios for our speakers. Dr. Alice Hoyt is a board certified allergist and leads the Hoyt Institute of Food Allergy. She has been practicing evidence-based medicine for over a decade. Prior to medical school, she earned a degree in nutrition, so she is well versed in the complexities of food allergies. She then completed training and earned board certifications in internal medicine, pediatrics, and allergy and immunology. During her fellowship at the University of Virginia, she launched the now national allergy-focused nonprofit organization Code Anna. At Vanderbilt University, she continued her food allergy-focused efforts before transitioning to Cleveland Clinic, where she helped launch its Food Allergy Center of Excellence. After working at such world-renowned institutions, Dr. Hoyt was excited to move back to the Gulf Coast and share her knowledge of food allergy with families. In addition to leading the Institute, Dr. Hoyt hosts the top-ranked food allergy podcast, Food Allergy and Your Kiddo. And Joan Edelstein is a faculty in school nurse credential programs at Sacramento State and San Francisco State. She holds a Master of Science in Pediatric Nursing from Yale and both a master's and doctorate or doctor of public health in maternal child health from UC Berkeley. She coordinates and leads countywide networking and professional development meetings for Alameda County school nurses. An Air Force veteran, Joan was professor of nursing at San Jose State for 22 years and went into school nursing in 2003 on a CDC Controlling Asthma in American Cities grant, then becoming coordinator of health services for Oakland Unified. She is passionate about school nurses' use of district policy and legislation to advocate for students' health. In the school nurse credential programs, she guides students in the development of district food allergy policies to keep all students safe and included at school. Joan developed one of the first food allergy board policies for schools in the San Francisco Bay Area. She took the lead on development of CA SB 568, which became law on January 1st, ensuring all students have access to life-saving epinephrine and expanding the routes of administration. Thank you for being here, Joan. All right, and our learning outcomes today are that by the end of the session, we will be able to list and demonstrate proper use of epinephrine devices, discuss the signs and symptoms of anaphylaxis, describe how school nurses can use district policy to advocate for students with food allergies. Ooh, whoopsies. Did I stop sharing my screen? No. Okay.
No, we see you.
You see me still? Okay.
And we see the screen. Yep.
Okay. I just lost my screen.
Okay, so we do have learning objectives, which I know our speakers will also share within their presentations. So let's go on to the next slide. And just so for those who are joining us for the first time, at the end of this session, we will be sharing a link to claim CEs for today's program. It was approved for 1 contact hours through AANP. And you also will be emailed the link within the next 24 to 48 hours. Thank you so much, and we will pass it on to our speakers. Thank you.
Hey, y'all. So I'm Alice Hoyt, as so lovely introduced. So I'm going to dive right in. Here are my disclosures. I'm advisor for Kaleo Mission Mighty Me. I'm the chairman of Code Anna. And really what my focus is today, again, I'm an allergist. So I'm here to answer all of your questions about epinephrine, when to use it, how to use it. First, I'm going to demonstrate how to use the devices, what devices are available, and then we'll also talk about the signs and symptoms and when to actually use the devices. Before I get started, though, are there any burning questions people have about the world of epinephrine and food allergies? And if there's anything in the chat, Olga, just holler it out. Because I definitely want to try to be engaging for people who are able to join us live. And then if you're listening to this on demand at another time, definitely reach out to me at drhoyt@codeana.org, codeana.org, whenever you have questions about epinephrine. So epinephrine is the treatment for anaphylaxis. I think I'm preaching to the choir about that, but you might not know what devices are currently available to treat anaphylaxis. And right now I'm going to go from the left of your screen over to the right of your screen. We have EpiPen. EpiPen, this is a trainer for it. And then there's an authorized generic of EpiPen, and it looks like this. So we have EpiPen and authorized generic of EpiPen. Now, if you've been around a while, you're like, wait, that doesn't look like the generic EpiPen. I thought that was this one, the Impax device, formerly Amneal. That's in the middle of your screen. Technically, that is a different device. And so a pharmacist cannot interchange an EpiPen or one of these. This is an authorized generic of EpiPen. So these are interchangeable. This one is not interchangeable. So if you ever have a situation where a parent says, oh, well, my doctor prescribed EpiPen, but then they gave us this and I don't know how to use it, that's a really big problem because these are separate devices. They are not interchangeable. Another epinephrine autoinjector is your AVQ, short for audio-visual cues. These are the different devices that are auto-injectors that are available to treat anaphylaxis. And then we have Neffy. And so I'm going to go through each of these, why I like which ones. I already mentioned that I am an advisor for Kaleo. Part of that is because my husband has used this device personally, and it has been did it save his life? I don't know, but it definitely stopped his reaction, and he is still with me, and he is treating patients himself. He is a physician himself. So I'm very grateful for this device. That being said, these other devices also contain epinephrine, are wonderful devices as well, for the most part. Now, I'm a doctor, and I'm going to tell you my honest truth about what I think about each of them. So EpiPen, old school, good, solid device. All of these devices, I'm also going to demonstrate how to use them. They all contain a safety. Most of them come in a package too. I'm not showing it here, but they come in twin packs. And so your patient is going to have 2 of each of the same dose. Here I demonstrate the yellow EpiPen. This is the adult dose, or the 0.3 milligram dose. That's for above 66 pounds. This is the EpiPen Junior. This is the 0.15 milligram dose. These are weight-based dosing. So we really shouldn't say like adult dose, kid dose, because there are plenty of kids that are getting this 0.3 milligram dose because, again, it's weight-based. The same situation with the Teva device. The green is the EpiPen Junior equivalent, the yellow, so 0.15. The yellow is the EpiPen, 0.3 milligrams. Before I move forward, I'll demonstrate how to use these devices. When you're holding the device, do not hold it like a detonator. I have heard of doctors putting their finger over the needle end, the business end of the device, and accidentally injecting their thumb. That is not what we want. One, because it's going to hurt that person, but 2, it's going to waste the device. And so the patient, the person who needs the medication, it's now delayed, right? Delayed administration of it. Delayed administration of epinephrine is a risk factor for fatal anaphylaxis. I'll get into that more in a few minutes. So you take it out of its carrying case, little plastic carrying case. You hold it like you're riding a bike. The orange side goes to the thigh. Ideally, your patient is laying down. If it's a child, you're going to hold that patient's leg. If you're right-handed, you're holding their leg with your left hand, and you're holding the device in your right hand. You are going to remove the blue safety guard. Blue to the sky, remove the red safety guard, and then the orange part goes to the thigh. You're not going to jab it. We don't stab. It's not Hollywood. You're going to apply it to the thigh. Just place it right against the thigh, and then you'll apply pressure. Hold for 1, 2, 3. When you remove the device, and you can do it more quickly than that, but I wanted to demonstrate that this plastic sheath is deployed to cover the needle. So with an EpiPen autoinjector, the EpiPen and the EpiPen authorized generic, which I'll demonstrate, your needle will be covered after use. These are single-use devices. I'm going to put that aside. So that is your EpiPen. Your Teva authorized generic, and it says the instructions on here, but who's really thinking about reading the instructions during the medical emergency, right? Like that's why you're in here. But what you do, and it says, number 1, quickly twist in the direction of the needle. So you see it's not quite as like easy to use, right? But it's still here. So twist off this cap. So it has a second cap. The EpiPen only had that one safety guard, right? This is not the safety guard. This is the cap. And then you're going to pull off this blue safety because right now the safety is on. This device will not deploy. Again, these are trainers. I am not concerned about injecting myself. These are trainers. Take off the blue cap. Now the device is ready to deploy. This one too is a 3-second hold time. You apply, and then you apply pressure. 1, 2, 3. Remove the device, and your needle will be covered. Now, I'm going to go to this device now. This is the Amneal or Impax device, formerly Amneal. We used to only have, maybe 10 years ago, we used to only have EpiPen and this. There were some other ones that came along, but really these were kind of like the most popular. This was considered the generic version of EpiPen, but like I said, this technically is not a generic. You open this up. This one's got a double cap situation too, right? So you take it out of its case, you pull off the ends, and again, the instructions are on here. So pull the end, pull the end. Red is the business end. Apply to outer thigh. Press pressure. This one says, and then remove it. This one says actually 10 seconds. I will tell you, when EpiPen first came out, and for years, it was also a hold time of 10 seconds until there were reports of lacerations in kids' legs because moms are holding kids down for 10 seconds, and it was really unnecessary. In any of these devices, it is not, the medication is not trickling out over 10 seconds or trickling out over 3 seconds. These are auto injectors. So the medication is administered in under a second immediately upon deployment. Why I'm not a fan of this device, though, if this is all you got, hey, it's Epi, is because it leaves the needle exposed. In a medical emergency, we do not want a used needle exposed. Just don't want that. And in stock epinephrine legislation and regulations, stock epinephrine being an epinephrine that is prescribed to an entity as opposed to a person, prescribed to an entity to be used in case of an allergy emergency for somebody who, for whatever reason, does not have a device. They might not even have a diagnosis yet. In a lot of cases, they either explicitly say it can't leave an exposed needle, or it's just very frowned upon. All legislation regarding stock epinephrine has a bit of heterogeneity in it, but be on the lookout for that. Don't try to stock epinephrine. I would not advise trying to stock epinephrine with this. This is a little bit more difficult to use than your traditional EpiPen. And again, it leaves that needle exposed. If it's the only thing you have, then it is absolutely better than nothing, right? But it's just not the most user-friendly. So then we get into AuviQ, which I think is the most user-friendly. This is also an auto-injector. It looks a lot different though, right? But they all contain epinephrine. Epinephrine is already being produced by your patient's adrenal glands to combat the allergic reaction. So this is just extra epinephrine because we never know as allergists which patients are actually going to make enough epi to counteract the reaction, which patients are not. Epinephrine will actually bind to the allergy cells that are causing the reaction and stabilize them. Epinephrine is what's called a mast cell stabilizer. Antihistamines don't do that. Epinephrine is also going to bind to the blood vessels to correct that low blood pressure. It's going to bind in the lungs to open up the airways, some things that antihistamines also don't do. So really, epinephrine is the first line treatment for anaphylaxis. So here's your AuviQ. I'm going to let it do its thing. It does actually talk to you. This is the trainer, but the real live device also talks as well. This is its carrying case. It comes in a twin pack.
This trainer contains no needle or drug and is for training purposes only. Do not use this trainer during an allergic emergency. If you are ready to use, pull red safety guard down and off of this trainer. Place black end against outer thigh. Then push firmly until you hear a click and hiss sound and hold in place for 2 seconds. 2, 1. Training complete.
So as
This
I said,
may be reused for training.
The live one talks to you too. This, you will not see a needle because this needle retracts. So this one, the needle's covered by a plastic sheath. This one, the needle retracts. Then we get into Neffy, the nasal epi. So this is a very exciting innovation because there's no needle, right? You insert in nose. You don't try to point it toward a septum, trying to point it up a little bit out, and that's it. You still want to have all the precautions of having your patient lay flat because that's going to give the best circulation. But I have had patients and my colleagues have reports of significant pain with this device. So don't think that, ooh, needle-free equals no pain. That is not true. Some patients, they do great with it. Some patients, and especially younger kids, they have reported really, really significant discomfort with the medication. So you might have any of these in your practice, and now you know how to use all of them. Well done, you. Are there any questions that I could answer right now?
We have a
Okay.
question in the chat.
Yeah.
Can you explain why Neffy needs to be used in the same nostril if second dose is required?
Um, there is a medication in this that helps clear secretions. So while I can't speak specifically for the company on that, I will say that it's likely because if they've already cleared secretions, then that's where we want to really directly deposit the next dose.
Thank you.
You're welcome. Okay, so signs and symptoms of anaphylaxis. Probably one of the biggest questions I get is, what really does anaphylaxis look like? Unfortunately, it is pretty common to hear, oh, well, you only use epi if the patient's having trouble breathing. Please dump that. That is absolutely not true. If the patient is having trouble breathing, we are well beyond where we need to be with this patient. Anaphylaxis is when you're having a system-wide reaction to a local action, like eating a cookie that contains peanut and your child has a peanut allergy, your patient has a peanut allergy, being stung by a bee here, but then you're having symptoms elsewhere. So that's anaphylaxis. Plenty of times in my practice and in the practice of other allergists, especially allergists who are well-versed in food allergy, if a patient eats something to which they're allergic and then starts vomiting, we're saying to give epi. That is because we do not want to wait for the patient to have more severe symptoms to stabilize the mast cells. As I said earlier, epinephrine actually tells the cells causing the problem to stop. But these are on your screen. These are some of the signs and symptoms that can occur with anaphylaxis. You're probably familiar with the congestion, the itchy eyes, the swelling, the coughing, the hives, right? I will say 30%-ish, 30-40% maybe of cases of anaphylaxis might not have any hives. So we really need to be mindful of these other symptoms and really clue into the history of what was just going on with the student or patient before the symptoms started. Because if somebody, say you're a school nurse, somebody comes to your office and says they just ate lunch, they ate their friend's lunch, they themselves have a cashew allergy. Their friend said that there wasn't anything with cashew in it, but now they're having hives and they just vomited in the bathroom. Likely accidental ingestion and definitely two systems, right? So you're going to treat with epinephrine. Something I really want to highlight, and I think one of the most under-recognized, perhaps undervalued symptoms, signs of anaphylaxis really is the altered mental status. What many patients describe when they're having anaphylaxis is this impending doom, this onset of impending doom where suddenly they feel, oh my gosh. And how this presents in our teenagers is they're like, oh my gosh, let me get in my car and drive home. And that is the last thing we want. Or, oh, let me run and get home to my mom. Or, oh, let me do something that is not necessarily the clearest thinking, but it's because they're having this, they're not in a good headspace. How we see this anaphylaxis present also in our younger children is just a sudden onset of a different behavior where they were like really happy and playful. And then all of a sudden they're just not. And they get kind of a look on their face like they're just not feeling well. And it was before, like 15 minutes before, they were totally great. So these are the signs and symptoms to look for anaphylaxis. I also want to highlight this form. This is the FAIR form, Food Allergy Research and Education. This is my favorite anaphylaxis action plan because it points out that if your patient has asthma, that's also a risk factor for a severe reaction. And here it really spells out nicely what to do with symptom onset. And even here, that old thought of antihistamines for mild symptoms, antihistamines may be given if ordered by a healthcare provider, because especially in a community setting where that patient is not necessarily with their parents or not in an allergy office, we want to err on the side of caution. And we do that by treating anaphylaxis promptly with epinephrine and not waiting around and saying, oh, well, let's give an antihistamine first and see if it gets better. That is old approach. The best practice is to recognize anaphylaxis promptly and treat it promptly. That's all I got.
Great. Thank you, Dr. Hoyt. That was really
You're
great
welcome.
information. Oh, sorry, Olga. I was stepping in. Did you want to say?
No, no, perfect. Thank you so much.
Okay. Yeah, so thank you. I especially, it was really helpful to me to understand the differences with the generic. I didn't, whenever I prescribe epinephrine, sometimes I just put epinephrine, but going forward, I think I'll put EpiPen, understanding that the pharmacy will replace it for with that generic if needed, because they're likely dispensing that Amgen, which with that exposed needle is not something I'd like either.
Not a fan of that. It's
Yeah.
also just not as easy to use. And so that's also something I counsel my patients on is I counsel them on make sure it is X device, whatever device I've prescribed, make sure that's the device you actually receive from the pharmacy. If it's not, let me know so that I can provide you guidance on how to use it. The other thing I advise my patients is before you accept that prescription from the pharmacy, check that expiration date. You definitely want to obtain a device that expires at least a year from now. You don't want to get a device that's going to expire in 6 months. That just means it's been sitting on the shelf for a long time. Let's get you a fresher device.
Absolutely. And I did just have one question too regarding that expiration date. I was told too that, looking, especially if you don't use epinephrine, which is great. And I'm not talking about the kids with food allergies with more likely, but like an adult with a food allergy, or somebody who has a bee sting allergy, much less likely to use their anaphylaxis, to look at that color of the medication.
Because they're not making a wise choice. Is that what you mean? Or because clinically they're less likely to need it? Especially in a venom allergy, that is absolutely potentially life-threatening. And if somebody with a known venom allergy gets stung and starts having even just hives, they are to promptly use their device. We unfortunately still see deaths from venom allergy. We had one locally a few months ago, and it's absolutely devastating. And so that's a population, and also our adults with food allergy. Those are populations where, unfortunately, fortunately, there often is a long period of time where they haven't had an exposure because adults are generally pretty good at avoiding, right? But that's where we really need to be diligent to advise them to carry their devices, keep their devices in date. Of course, if they have an expired one, that's all they got, then use it. Um, but use it and call 911 immediately. But absolutely, especially our venom patients, it's so sad to hear those stories.
Oh, absolutely. No, I didn't mean to have it sound like no, I totally agree that they should have an EpiPen too. I guess my question, I wasn't stating it properly, was about that if they have an expired pen, like you're saying, and I do tell
Mhm.
them if that's all you have, great.
Yeah.
When should they not use it based off of, I heard the discoloration of the medication itself within the device is another time. Because you
Yeah,
mentioned expiration dates.
that's what you're going to hear is don't use
Yeah.
it if it looks cloudy, if any of those things. That's why you want to have an in-date device.
Okay.
At the end of the day, I suspect most allergists would say if that's all you have and you're 30 minutes from the most recent ER or closest ER and you just got stung by 3 honeybees and you know you're allergic, then you want to give yourself the best possible chance. The adverse events from epinephrine are pain at the injection site and increased heart rate. When you get into Neffy, it can have more of that rhinorrhea, headache, things like that. But none of them have these prolonged, long-term adverse reactions. My husband, who is an electrophysiologist, he says he would rather deal with a high heart rate than no heart rate. So we really need to get away from, well, let's give antihistamines first, and let's do epinephrine. And that's also why it's so exciting that there are more devices coming on that have longer shelf life. The Neffy is typically a 2-year shelf life. Anafilm is coming out, which is going to be an epinephrine film that goes in the mouth. All these things also can have different adverse effects, but at the end of the day, it's great we're having innovation so patients have options for what's the best treatment plan for them. But if they don't have it with them, they can't use it. And that's why it is so important, especially as our food allergy focus group, to really encourage everybody, if they haven't seen an allergist or even their primary care doctor about getting an updated prescription, we need to do that.
If I may jump in with one of the things that EpiPen for Schools tells school nurses because they sometimes have difficulty restocking after the expiration date, is they will extend the expiration date and specifically say it's fine to use it as long as it's not discolored. So the approach that they take is a little bit different than, which I appreciate what you're explaining. So to know what school nurses are being told.
Yeah, it's really interesting, the EpiPens for Schools program. I do a lot of writing stock epinephrine prescriptions, and there have been some challenges with getting in-date devices. I would say the legislative and regulatory issues of a nurse administering a device that is expired is really challenging. And ultimately, it comes back to we as food allergy advocates need to continue to work hard to make it the norm to stock epinephrine and have that just as normal as having a fire extinguisher in our schools.
Thank you so much. I think it's very important that we have a school nurse and an allergist on the call today, because these are some of the things that I think come up logistically. Sometimes, unfortunately,
Yes.
it's not up to us. Like, there's that shared responsibility that we have to work towards as a team between all of the disciplines involved. And I know we are now at the time to pass it on to Dr. Edelstein. Thank you.
Thank you. Okay, let me
And
share my
while
screen.
we're transitioning, I also wanted to just thank Dr. Alice Hoyt and the Hoyt Institute of Food Allergy for sponsoring today's session and making it available at no cost to all who wanted to attend. And we will be sharing the recording as well as the CE link at the end of the session.
Great. Thanks so much. Thank you, Alice. So I'm going to be talking about the policy part and why it's so important to use district policy as well as legislation to advocate for student health and the rationales for that. Let me just pull up my screen. And start the slides. There we go. That went pretty fast. So let's start right off about knowing your state laws for stock epinephrine. And I know there's two of us here from California. California does mandate stock epinephrine in schools, both public and private schools, and they have since 2014. So I'm just going to mention, while I'm on that subject, SB 568, where it says making sure that epinephrine was available to everyone. We just did that bill last year. It went into effect January 1st. Two things about it. Number one, it was a cleanup bill. What happened was, long story short, we discovered that in the preschools, not all preschools had access to epinephrine. If this preschool was in a separate building, they often did not have epinephrine provided. If they were in the same building as an elementary school, then the epinephrine generally was available to them, but we also discovered that there were school nurses who were being told specifically by their administration that they may not use the epinephrine for preschool students. And our laws that I was involved in 10 years ago said persons suffering from or perceived to be suffering from anaphylactic reaction. And it didn't say persons except for preschool students or persons except for adult transition, etc. And so it was basically a cleanup bill to make sure that everyone knew that this was for everyone, anyone, anybody who came in. It wasn't just elementary and secondary schools, which unfortunately had been called out in the legislation in relation to stocking and training. And unfortunately, there was a misinterpretation somehow in some places. And unfortunately, also, that included EpiPen for schools. They were only providing epinephrine for elementary and secondary schools when the California Department of Public Health took over. Also providing stock epinephrine standing orders. They were only writing orders for elementary and secondary schools as of this year. About 3 months into 2026 was when they were able to provide the standing orders for other than elementary and secondary schools. At the same time, the year before, California School Nurses Organization, CSNO, had sponsored a bill to expand epinephrine delivery systems because Neffy was becoming available. Unfortunately, at the time, it had died in appropriations. So last year, when we did our SB 568 bill, you don't have to know the number, I'm just used to saying it, CSNO reintroduced the bill. They sponsored another bill. And I said, well, if we're going to have expanded delivery systems, let's make sure we align with their language. And we made sure to replace epinephrine autoinjector with epinephrine delivery system in our bill. Unfortunately, their bill once again died in appropriations. It didn't make out of Appropriations Committee. And so our cleanup bill was the only one because we had aligned with their language. Now, all of a sudden, our bill said, okay, epinephrine delivery systems. And that's one thing I always recommend that people follow legislation, like pick some legislation that you're interested in. Go to Legiscan at your state. There's a way to track the bill, watch it as it goes through, listen to the hearings, and find out what happens. If something doesn't come through, check with the sponsor's office, and the staff person will likely tell you what happened and why the bill didn't go through and where the hang up was. Because the politics, I don't mean the politics whether right wing or left wing or Republican or Democrat, just the politics of the situation makes a big difference, and it's helpful to understand what's going on. So definitely know what your state law is for epinephrine. And this was 10 years into the program, and we didn't know that there was a problem. So you never know when an issue is going to come up. So the Asthma Allergy Foundation of America has a state honor roll, and they tell you specifically different states and where they are. And for the state honor rolls, only Connecticut, they count DC as a state for some, or they just don't say it's separate. So Connecticut and the District of Columbia were the only two state and non-state that actually made the honor roll. And I was thinking it wasn't quite updated because we didn't have all the epinephrine delivery systems yet. It was a 2025 document. And I wondered why we didn't make the honor roll in California, because we mandate epinephrine. And I'm going to get into that in a minute. So there were 10 states we did make honorable mention. For legislation, the AAFA does have an advocacy toolkit that will help you when you go to legislators. And only 25% of states mandate stock epinephrine in schools. But I did look at the map, and I only counted 10. So I think it's really either 20% or they're missing some stars. So California, I think I was looking at people who were here. We have one person from California. Ohio, Maine, and Pennsylvania, to my knowledge, don't mandate but allow. Would you please, for those of you who are from those states, correct me if that's not the case? Okay. So there is a wonderful map that shows whether your state mandates it or allows it. And of course, we absolutely advocate making sure that that you help districts to have epinephrine in their schools. So I was curious, as I said, why California was not on the honor roll. I was kind of like miffed. I thought we should be on the honor roll. And in AAFA, they have a methodology that's lined out in their document. And they have these categories on medication, identification, reporting, management, health services capacity, and medication and treatment they give you extra credit for. And they cover, I'm going to go to that methodology, they cover both asthma and allergies. So they cover both albuterol and epinephrine. In California, we now have the option, it's not mandated, the option of providing albuterol in the schools, but I'm not going to be talking about that. So I went down to see what are the standards that create these. Pardon me for scrolling. I always hate when people scroll on a shared screen. But can you see this clearly, or do I need to make it bigger? I'll assume that you see it clearly unless you tell me otherwise.
It's perfect. Thank you.
Okay, thank you. So I'm not going to go through each of these, but as you can see, medications, it says, you're required, and that students have a right to self-carry, and that the staff are covered from liability. We actually had to do a cleanup bill in 2014, 2015, when our first epinephrine language came through, because not all physicians in all counties were able to write standing orders. What was happening is the risk management companies were telling them either they wouldn't be covered for writing prescriptions or standing orders for students they didn't know, or they were going to jack up their rates. And I was a little bit miffed to think that, since when does risk management get to tell you how to practice medicine? In any case, what we had to do was go back with a cleanup bill and make sure that liability was waived so that all the physicians could be covered who are writing standing orders. And so that's a really important, that's now in any medication legislation that goes through in California. And that's something important to have in your state. Identification and reporting. It makes sense to me. I always teach the school nurses to make sure that whoever's writing the standing orders receives an incident report when it's used, because legally they're responsible for the standing orders that they write. And there are states that require reporting, which is great because then you can get data. And if you don't report, it's kind of difficult to get data. With EpiPen for schools, you've got to report to them in order to get having it replaced. Neffy, I will say one thing about Neffy. Neffy also tracks, you have to let Neffy know if you were using it and replaced it. Neffy is free for schools as EpiPen is for schools. However, you need to know that there is a $50 fee per year per school for Neffy to track the data. We are talking to them now about having that fee waived for Title I schools, and I think they have a checkbox now when you go to order it that you can waive that fee for Title I schools. But there is a charge for Neffy for administration, not for administration of medication, but the administrative charges. And then management policy, you have to not just have the epinephrine, but have protocols. Health services capacity is really where I got caught, because what it says, and I love this, is that has adopted a policy that each school will have at least one full-time nurse. And California will never meet that, because half of our school districts have no nurse at all. There is no mandate for, or ratio for school nurses in California as there is in New York, for example. And each state has their own determination of how many school nurses should be included. And if any of you from different states happen to know, I know we're not a group of school nurses, if you happen to know, Connecticut obviously has a nurse in every school because otherwise they would not have made the honor roll. This is what it takes to make the honor roll. And then there's extra credit if if you've got these different things. So let me go back to advocate for school nurses in your states when you advocate for epinephrine. So there are resources that give you access to laws and guidelines by each state. You can look up your state to see what's required in schools and how to find out. As I mentioned before, all states and 50 states and DC either mandate or allow, and once again, only either a fifth to a quarter of states actually mandate it. And my personal and professional feeling is it should be mandated in every state because there is no state without children in their schools who have food allergies and may potentially anaphylax. There are great resources through the Asthma and Allergy Network for schools to help set up their programs so that we also have epinephrine self-carry, not just having stock epinephrine, but students who have epinephrine to self-carry. If they have the bandwidth to self-administer, depending on their age and their ability and where they are on anaphylaxis, there should always be someone around who can help. But for them to be able to self-carry and administer and determine what the stock epinephrine laws are. So we feel strongly about advocating for mandatory epinephrine in the schools. There is an advocacy toolkit specifically about how to go about getting legislation. And I know a lot of school nurses in particular, I don't know about nurses in clinical practice. School nurses tend not to be loud and involved in legislation unless they're asked to come testify or make a statement of support or oppose a particular bill. I'd like to ask, for those who are here, have any of you been involved in legislation at all? Or Olga, perfect. And can you just briefly describe, and Alice, just what kind of legislation has it just been stock epinephrine? Has it been epinephrine in different places? What kind of advocacy?
Olga, you want to go first?
Yes, so I've been involved in a number of different advocacy initiatives. Some have to do with epinephrine, others had to do with training for the restaurant industry, it had to do with accommodations, different accommodations, including also implementation of CDC guidelines in the school district. So I've been involved with advocacy and policy on both sides, advocating with Nassau County legislature, state legislature, and also federal. So it's
awesome. Yeah. Yeah. And
I do most of my work on the state level. I find that's where a lot of impact can be made, and worked with Connecticut, Ohio, and most recently Louisiana. We passed two separate laws, one that permitted schools to not just stock epinephrine, but also stock albuterol, naloxone, and gave the Department of Health the agility to add to that list as needed instead of having to go back to the legislature, which if you've ever done any sort of advocacy work, is quite a laborious and political process. Did a mirroring law that allows non-school entities, so restaurants, camps, early child care centers, to again, not just stock epinephrine, but also albuterol, naloxone, and again, giving the Department of Health that same latitude there to add to the list. We also required the Department of Health to create standing order protocol as well as standing prescription to take that whole we can't find a prescriber out of the barrier list.
Actually, speaking of policy, Joan, I just put something in the chat, policy pantry that actually came out of Thomas Silvera's work and a project that he's working on, which hopefully helps streamline and make it easier for advocates, for organizations, nurses, physicians, researchers, et cetera, to easy access laws and advocacy tools and policy information on one platform. And he's actually just emailed me literally a few days ago, and I thought I'd share with this group in case anybody wants to provide feedback and email him with their suggestions and whatnot. So I thought it was a cool project because I think it will be very helpful for all of us to kind of have it all in one place.
Yeah, he's done a nice job of that. I think the aesthetic of it
Yeah.
is cool looking too.
Yeah. So if anybody wants to check it out and give him feedback, it's in the chat.
Thank you. Awesome. What about the rest of the group here? If there's anything that you've done, or if there's any obstacles or barriers that are stopping you from being involved, if you could share. Don't feel pressured, but it would be great. We're fortunate to have a small group during the summer, so if you'd like to share, we would love to hear. Or you can put it in the chat.
I just also want to take a note of time. I have 10 minutes. I just want to make sure we have time
Okay, I'll
for
be done.
Q&A. Thank you.
Okay, so one of the things we do is advocate for school nurses to make sure you have data. It's so important to get data and provide the data. Nationally, we know how significantly food allergy is increasing. One of the important things that came out of the EpiPen for Schools program, and these are data from 10 years ago, so it wasn't even quite as expanded as it is now, is that 25% of first-time anaphylactic reactions at school were in students who had no known previous food allergy diagnosis. And so that's one of the things that helps us when we say we really need epinephrine. And there are links. You'll have a PowerPoint, and we'll be sending out the PowerPoint with the links that I'm not going to open right now. But these give you an example by state. Massachusetts, there are all of the districts listed. You can click on any of the district and see if they have a food allergy bill. And I have a link to one of the specific districts. New York, it's optional to provide data. This is the reporting part. California has no requirement to report. We tell school nurses to report, but CDPH, for example, is not asking for reporting. And we really need to have data. And legally, the physicians should be backed and know exactly what's happening with the medications that they are providing standing orders for. School districts are some of the most important places to go, regardless of whether it's mandated or allowed. If it's allowed, go to your school boards. I say go to your school boards. You're not at the school districts, the people who are on here, but there will be school nurses who will be watching this. Go to your school board. We are always available to help you any place across the country to work with your school board and help you stress to them why it's so important to have epinephrine in the schools. Not all districts have policies for students with food allergies. That's why we did one in the Bay Area. And there are many, many more districts that do have food allergy policies. Epinephrine, stock epinephrine is in the medication policy usually, but there's often not a separate policy about how to manage students with food allergies. And so some of the things that we recommend as far as food allergy policies are things like non-food treats for birthday parties, because you don't know what kind of food is coming in from a parent's home. And it's difficult to say, oh, it has to be bought without even knowing what the ingredients are, or if it's a nut-free facility, for example. For that, we do the Teal Pumpkin Project. I have never given food treats for Halloween, and the kids love the rubber duckies and the bouncy balls. And so there are resources to provide non-food treats. And with the data, of course, include your district. Here are some resources for you when you're working both on legislation and your policies. And I'm going to skip down to Wright's Law, which is at the very end. I always encourage going to Wright's Law website because they will list all the lawsuits that relate to food allergies. And what we've learned from them is across the country that, and again, I'm talking about school districts, but I think it's likely any place else, that districts that have food allergy policies and try to stick by them, no district is going to be perfect. You do the best that you can, but if you're focused on the food allergies and you're trying to do your best to keep students safe, the districts tend to prevail in the lawsuits. If they don't have a policy, if they just say, oh, well, the nurse wrote the healthcare plan, so we followed that. But if they don't have a protocol and policy that says this is what we do with students with food allergies, then generally the families tend to prevail. So I think those are basically what I want to say. And my contact information, if you have any questions to follow up, I'm always available. That's at Sac State. And if you have any questions now, let me unshare my screen.
Thank you, Joan. Thank you
Great
so
info,
much.
Joan.
All right. Are there any questions? All right, we have a couple more minutes. So if you are interested in asking questions, please unmute yourself and go ahead, or you can put it in a chat.
Yeah, while you're doing that, I would just like to give one example. When we passed a food allergy policy at one of the districts I was at, and this I think applies any place, and the faculty were kind of like, to have treats that are all food allergy safe are not going to be interesting. The kids aren't going to want them. And so we did, with the administrative team, I went out and bought a whole bunch of treats and put them on the table when we were going to discuss them. And I didn't have a plan. It turned out that one of our principals from the high school took one look, and I'm not exaggerating to you, she took one look at those, puffin muffins, and she said, "Oh my God, you brought food that I can eat." And she was so excited. She had been going to meetings for years. She had food allergies and she wouldn't touch anything. And we had food that had labels and were allergen free. And I said, she really wasn't a plan. This is how children are going to respond. And so I think that's applicable for any places when you present policies or plans about protecting people and children with food allergies.
Thank you, Joan. I'm going to stop the recording so people have more freedom to ask questions.